Hi, everyone. Greetings and welcome to day 3 of the Pride Study Wrapped Research Year in Review 2024. We're now on the second half of our 4-day storytelling through data extravaganza. My name is Daniel Moretti. I use all pronouns with positive intent, and I'm Program Management Director at PrideNet. A brief visual description of myself is I have brown curly hair, a mustache, light brown skin. I'm wearing a white shirt with tons of colorful hearts to represent my love for everyone, and a pink bow tie because on Wednesdays we wear pink. Just a quick note about our webinar series name. Wrapped is a play on how many streaming services offer a wrapped highlight of your past year. It does not mean wrapped like we're done. We're not going anywhere. Just like our resilient LGBTQI plus community, we can't stop and we won't stop showing up for ourselves and one another. This new webinar series that today is part of was launched to create more opportunities for the Pride Study to share research results back with the community and to build more opportunities for researchers and community members to connect with one another. I see a lot of familiar names of folks who are rejoining us from previous days. We see you and we appreciate you. And I also see some new names. Welcome. We're so grateful to have you here and creating community space with us all. It's my pleasure to introduce Dr. Mitchell Lunn, co-director of the Pride Study and PrideNet, who's going to provide brief welcome remarks today.
Great. Thanks, Daniel. And thanks, everyone, for being here today, joining us for the Pride Study Wrapped Research Year in Review 2024. My name is Mitchell Lunn. I use he and him pronouns. I'm an associate professor here at Stanford. A visual description is I'm a middle-aged white guy with the kind of brown spiky hair and brown facial hair wearing a blue polo shirt today. We are very proud of and thankful for all the collaborators that have worked with us over the years, many of whom you'll hear from today and tomorrow on our final day of the Pride Study Wrapped sessions for this week. And since our first paper in 2019, we've now published 71 papers and look forward to continuing this productivity for the years to come while we continue our ongoing commitment to engage and partner with LGBT communities all along the way. We know that LGBTQIA plus communities, especially trans and gender diverse communities, are now under specific and directed attack. And so we need each other now more than ever. Thank you all for joining us today and for your continued support, participation, and dedication to making the world a better and healthier place for LGBTQIA plus people. Thanks so much, and I'll send it back to Daniel.
Thank you so much, Mitch. We really appreciate it. So the agenda for today, once we finish with the introduction, we are going to hear from 3 different studies and researchers. We're going to start with LGBTQI plus people's experiences with chronic pain with Dr. Andrea Chadwick. And then we'll be moving into hearing about chronic pelvic pain among transgender men and gender diverse adults assigned female at birth with Dr. Diana Tordoff. And then we'll be hearing about measuring concerns about muscles with transgender women from Dr. Emilio Compte. And then make sure you stay to the end. We are going to have some exciting pregnant updates as well as some closing. So there will be 20 minutes for each presentation. It'll be 10 minutes of presentation, 10 minutes of Q&A. We have a little bit of wiggle room today, so if folks have a lot of questions, we'll make sure to get to them all. I did want to give a little bit of a content notice that the studies being presented today, sometimes we'll have data that we'll be sharing about experiences, pain, trauma, and or discrimination. So just want to make sure everyone is aware, and we encourage you to practice self-care in the way that's most supportive for you. And before we get started, I did want to give a little bit of context about who we are. So we're going to start with PrideNet. We are based out of Stanford University School of Medicine, and we're a national network that focuses on catalyzing LGBTQIA plus health research. And the way that we do that is connecting community with ways to participate in trusted health research, but really importantly, creating opportunities for community input to inform all stages of the research process. My colleague Elle will drop in the chat a link to PrideNet's website that will have more information if you're interested in learning more about what PrideNet does. And one of the studies that we conduct community engagement for, and the focus for today's webinar, is about research from the Pride study. So the Pride study, we're also based out of Stanford Medicine. We are the first national online long-term health study that's looking at LGBTQIA plus physical, mental, and social health. Really want to underscore that this is a study that's made by us and for us. So as you can see, the staff, our founders, part of the LGBTQI plus community, really advocating and working towards better health outcomes for our entire community. Participation is primarily focused on completing an annual survey once a year, study your health over time. You might be invited other ways that you can choose to participate. The eligibility criteria is people who identify as LGBTQI plus or sexual or gender minority, at least 18 years or older, living in the US or territories, and comfortable reading and writing in English. We are currently at 30,000 plus participants, but we might be missing you. If we are and you're interested in learning more, my colleague Elle put the link in the chat so you can learn more about the Pride study. Wanted to also amplify the voice of our network and our participants. So I'm going to play a very short 2-minute video where you're going to hear from our network and participants, real people that are part of the study, part of our work, who are going to talk about from their perspective what they see as the Pride study, how it's different from other research.
Historically, research for LGBT people hasn't been inclusive of LGBT people. It hasn't asked us, what do we care about? How do we want to be treated? It's been very othering versus the Pride study, which is very inclusive, considers our perspectives as really first-class perspectives.
It centers community, which should be in every aspect of life. We have to understand that not only are we experts, but the communities are expert as well.
The Pride study asks you what is important. How should questions be phrased? What do you like about medicine right now? What do you dislike about the medical care that you're getting right now?
It isn't a one-way extractive flow of information. When you enter your own information into the Pride study, you can expect those findings to come back to you. You're meaningfully engaged throughout the entire process.
You know, when I take other studies and they ask me to choose one ethnicity, it's like, okay, which one out of the three? Is it the one that I have the most genetically, the one most culturally that I identify with, or the one that people see me as? Just that tiny fact that they let me choose all because I am all.
At every step of the way, there are people with LGBTQIA, 2S plus identities creating the questions, doing the recruitment, doing the advertising, producing the resources.
This is, by and for LGBTQIA people in so many ways. And I think in terms of what our members have had to say, what people who have engaged with us have had to say, they really do feel that difference.
The more people that we have, the more diverse population that we have contributing to the data that we can share with researchers, the health outcomes will be applicable to more people and reach people who in the past have not been helped.
Well, huge thanks to all of our participants and our network that make this research and work possible. So without further ado, we're going to dive into the presentations. It is my distinct pleasure to go ahead and welcome Dr. Andrea Chadwick, who's going to start us off with the first study being presented today.
Thank you so much, Daniel. I'm going to go ahead and share my slides. So my name's Dr. Andrea Chadwick. I'm at the University of Kansas. My pronouns are she, her, and for a physical description of myself, I am a middle-aged white woman with what they call blonde hair, a little few grays coming in at the top, wearing a royal blue sweater with a necklace that my wife gave me for Christmas. And I'm here to talk to you today about my experience in using Pride study data to really deeply investigate LGBTQIA people's experiences with chronic pain. So The journal that my paper was published in is called Pain Medicine. It's one of the top journals in my field. I am the lead author, and just for a little bit of context, I am a pain management physician. My specialty training was in anesthesiology. I did a pain fellowship at the University of California, Los Angeles. I also have a master's in clinical research. And I've been at the University of Kansas now for about the past 10 years. I'm a Kansas native. Go Chiefs. My publication title was Localized and Widespread Chronic Pain in Sexual and Gender Minority People, an analysis of the PRIDE study. So chronic pain is defined as the pain that a person experiences for 3 months or longer. Other studies have been reported that up to 20% of American adults experience chronic pain at some point in their life. But most of the research that's been done and published in journals is typically with cisgender and heterosexual populations. And so alongside my co-authors and colleagues, we analyzed data from 5,397 participants who completed the PRIDE Study's 2022 annual questionnaire. And really our goal was to identify and describe the experiences of chronic pain amongst the LGBTQIA plus persons who participated in this questionnaire. So as far as innovation and what we brought new to the table from what's available in the medical literature is that this is one of the first studies really exploring if chronic pain is widespread among LGBTQIA plus persons. We also were able to granularize that in terms of what parts of the body people experienced chronic pain in this survey. And I wanted to quickly just talk about why widespread pain is so important to me in my research. When we talk about widespread pain, it's pain that exists in multiple different body parts. As far as how we define it, typically it's in 3 or more regions of the body. And what we know about people who have widespread pain is that oftentimes it indicates that the central nervous system, meaning the brain or the spinal cord, are actually part of what's driving the chronic pain process, as opposed to other types of chronic pain called nociceptive or neuropathic pain, which is really driven by peripheral processes. So what did we learn from our study? The findings from our study highlight that chronic pain in certain areas of the body and having chronic widespread pain are commonly seen in LGBTQIA participants in the PRIDE study. Interestingly, when we broke it down with both gender and sexual minorities, the majority of the chronic pain that LGBTQIA participants experience is in the neck, upper back, and lower back. And that's typically what we would refer to as spine pain. So really from neck all the way down to the lower back spine. Approximately 1/3 of our participants who identified as non-binary, another gender identity, a transgender man, queer, asexual, demisexual, gray ace, and another sexual orientation reported having chronic widespread pain. So what do these findings mean for our communities? What our findings show is that there are increased numbers of LGBTQIA persons who report chronic pain. In our cohort of persons, it was approximately 55%. And when you compare that rate of chronic pain to other studies that have been reported in both cisgender and heterosexual persons, that's really only about 20%. So we're seeing a much larger prevalence of chronic pain in the LGBTQIA community compared to our cis and heterosexual populations. Also, and notably, our findings highlight that chronic widespread pain, again, that pain that exists in many body regions, is present in increased numbers of LGBTQIA plus persons, and that rate ranged from about 15 to 37% among sexual and gender minority groups. And when we compare that prevalence of widespread pain to other reported studies, again, with mostly cisgender and heterosexual populations, those rates are about 10%. So again, we are seeing higher prevalence of chronic widespread pain in our LGBTQIA plus cohort from the PRIDE study compared to what we know exists in the cis hetero population. So why should we care about chronic pain? Chronic pain is what I do every day. I see patients, I study patients with chronic pain. What we know is that chronic pain is a leading cause of disability and decreased quality of life for those who suffer from it. And it is very important for healthcare providers in any specialty to understand that there is an increased presence of chronic pain in LGBTQIA plus persons. And in that regards, they can help provide better support and healthcare to persons who do have chronic pain. So what's next? Future studies are actually being planned currently to understand what factors lead to this increased chronic pain, as well as specifically the chronic widespread pain in LGBTQIA plus persons. So I did want to share that back in September, we did receive a grant from the National Institutes of Health to really take this study and what we learned from the PRIDE study to the next level. This is my team of colleagues here that range from the Ohio State University, my home institution of University of Kansas Medical Center, as well as UCSF and the University of Michigan. And all of these people you see here are very, very just wonderful people who are excited to get this project going. So I did want to share how this study will differ from what we did with the PRIDE study. We're going to be following people over time. And so this is what we call an observational study. And our goal is really to see what happens to pain and pain-related symptoms, things like fatigue and sleep, as well as other physical functioning modalities, how these change over time in gender minority persons who are initiating and taking gender-affirming hormone therapy. We'll be using questionnaires to do that. But I also use a variety of other objective, meaning tools that we can measure with, tests in my laboratory. So we use something called quantitative sensory testing that allows us using specific tools to identify how someone responds to a painful stimulus. We'll also be using brain imaging through an MRI to see if the areas of the brain that respond to pain change with gender-affirming hormone therapy. And then Dr. Laura Black, who was my colleague at the University of Kansas, but she and her husband just relocated to Ohio. She is a pain psychologist, and she'll be doing qualitative interviews with our participants to investigate how gender-affirming care and hormone therapy affects psychological well-being and how that intersects with the experience of pain in our gender minority population. And I did want to thank my team, my wonderful team of people who work with me, and thank the NIH and the Department of Defense for the research support that they've given me. And because you all have shared so much with me, I did want to share a picture of my wife and my children who give me inspiration every day. Thank you.
Thank you so much, Dr. Chadwick. And this photo gives me lots of queer joy, and I really appreciate you sharing it with us. I'm going to go ahead and jump into, we have some questions from the audience. So I'm going to go ahead and read the first one, which is, how can your research findings influence and change the approach to chronic pain treatment and management for trans, non-binary, gender non-conforming folks accessing care through various health providers, especially in the context of current chronic pain care pathways and their success rates?
That's a really great question. I think the way that this data has inspired me to learn more about pain care for our gender minority communities is really being able to engage with other providers across my community and campus, but across all campuses that provide gender affirming care to gender minority patients. And so one thing that I've been able to do is work with Dr. Quinn Jackson, who is our LGBTQIA plus primary care director at the University of Kansas, as well as our gender diverse clinic, to create pathways for assessing chronic pain. It was one thing that our gender affirming providers at the University of Kansas were not routinely doing. And once we got this data and I was able to share it with them, they were very, very surprised to see these rates of chronic pain. And I think part of it is when our gender minority friends are accessing care, maybe the pain is not at the forefront of the provider's mind because there's many other things to discuss. And so I think really that knowledge is power, and that when we see the prevalence like this, it really brings that to the forefront in the provider's mind. And I really would like to see chronic pain and pain care embedded within gender diverse clinics across the country, given that. And I do hope that this research will inform better precision therapies for gender minority persons, because too often I find that our treatments in chronic pain are very cookbook, and aren't really designed to get to what patients want. They're more driven by what the provider can offer. And so I'm very much looking forward to how this could inform shared decision making with patients.
Thank you so much. We have your impactful study is surfacing lots of questions, so I'm going to go ahead and move to the next. It's in the chat, which members experienced widespread chronic pain at or near the 37% rate? And then a second part is, and which were at or near the 10% low end rate?
So I can actually pull up the study if you would like. Let me see if I can get that, because I feel like showing the tables would be really beneficial. Okay. So as you can see here, when we look at widespread pain, this is for our gender identity group. So you can see here that widespread pain for cisgender men in this study were about 16%, for cisgender women, about 25%. For our non-binary persons, it was 36%, trans men, 31%, trans women were 21.3%, and another gender persons were 37.7%. And when we scroll down, I hope this is big enough for everybody. I made it quite big for my old lady eyes. But when we look at our sexual orientation groups here for widespread pain, our asexual, demisexual, and gray ace persons were at 33%, bisexual, pansexual was at 26%, gay and lesbian, 21%, heterosexual, straight, 29%, queer, 33.2%, and in our another sexual orientation group, it was 35%.
Thank you so much for sharing that, and want to remind folks that the links to the community-friendly summary and then the manuscript that Dr. Chadwick just pulled up are also in the chat from my colleague Elle. Okay, we'll move to the next question, which someone shared in the Q&A. I know that you have future research planned, but what are some of the mechanisms you think might explain the increased rate of chronic pain and widespread pain among LGBTQI+ participants?
That is such a fantastic question, and it's something that I study every day. So without getting too nerdy, I'm essentially kind of a fibromyalgia doctor. Now, fibromyalgia is just one condition, but it is under a scope of chronic pain conditions called nociplastic pain conditions. And these include things like migraine headache, temporomandibular disorder, irritable bowel syndrome, just to name a few, but there's 10 of them. And what we know about these types of disorders is that they are really driven by changes in the brain and spinal cord that amplify pain signaling throughout the body and also decrease the body's ability to fight pain from the brain down. We all have this innate ability to do it, but we know what happens in these types of chronic widespread pain conditions is that that's very decreased. And so my main hypothesis here, when you look at risk factors for developing chronic widespread pain syndromes that I've described, the main one is stress. So I do think that minority stress and other types of stress, whether it be adverse childhood events, adverse events throughout life, traumatic incidents, injuries, all of those could be stressful. And so what we know about that stress is it causes changes throughout the body, chemically and molecularly, and that those changes can actually lead to the brain and central nervous system, creating this kind of amplification of pain signaling.
Thank you so much for sharing that. This is possibly, I see this question is related, so just let me know if there is any additional that you would want to share on this. This question, does this data provide a different quote unquote normalcy levels of chronic pain for LGBTQ folks as opposed to cis and or straight populations?
I mean, so it's really hard to know in the studies that were done previously, those population-based studies. A lot of them were done with very large databases that didn't get into the granularities of sexual identity or gender identity. So it is hard to know if what's been previously published and what I've said is mostly cis hetero, whether or not there could be LGBTQIA plus folks in there as part of that data. And so I do feel that what we're seeing is fairly representative of the LGBTQIA plus population. And so I find these data, given it is a rather large subset of LGBTQIA plus persons, to be accurate and valid.
Thank you so much. We have a question in the chat. Will your research address chronic pain in non-binary folks who are not taking hormones but do social and or surgical transition?
That is such an awesome question. Yes, we actually have a group that will be our gender minority persons of all different identities being able to participate in our study. And those persons who are not on hormone therapy will make up that group.
Thank you so much. Next question is, do you have any info from the study on if/how people are getting relief from chronic pain?
And that's a really wonderful question. I combed through the annual questionnaire trying to find any and all questions I could that would granularize what treatments patients are using for chronic pain. And I did not find much granular data there. So that's another thing we're going to be using in our study, is identifying in our chronic pain patients who join the study what types of therapies they use, whether it's more Eastern modalities, more complementary and alternative medicine, or integrative approaches versus medications, et cetera. Many patients use a combination of all of them. So we will be assessing, number one, what therapies they use, but in our qualitative interviews, we're really wanting to identify what type of pain care matters to our gender minority friends.
Thank you so much. And so second to last question in the Q&A, do you think the high rates of connective tissue disorders in autistic people and the high rates of autism in the trans community play a role in rates of chronic pain for gender minority people?
That's another fabulous question. What a smart group of people asking questions. I love this. There's not a lot of data right now on neurodivergency when it comes to the intersectionality of chronic pain and gender identity. And so I think that's a really important topic that deserves mention. But I do want to mention specifically that we do see higher rates of chronic widespread pain, specifically the nosoplastic pain I was talking about, the chronic widespread pain in persons who have connective tissue disorders or autoimmune disorders. So those persons do have a higher risk factor for developing that chronic widespread pain.
Thank you so much. And so the last question is, or second to last, there's more of a comment and then a question. So
Okay.
this question is, with the sharp increase in pain I am noticing in members of our community and in my own body recently, and with other data previously reported in the literature, it seems relatively easy to correlate to the impacts of systemic impression to pain experiences. I wonder if there might be a way to gather data over the next several years to oppressive policy and social conditions to assess the effects on our community.
That's really, thank you for bringing that question up. So I actually have some data from my own group here alongside Dr. Quinn Jackson, our LGBTQIA plus primary care director, where we actually had been gathering some data in our gender minority persons getting gender affirming care at the University of Kansas. And during the halfway point of our study is when the Missouri Attorney General, those of you who don't know, Kansas and Missouri are like best friends, and Kansas City is right, like they're kissing Kansas City. The Missouri Attorney General banned transgender care for persons in that state. And so we actually have data from before that Missouri Attorney General ban and after, and we did find statistically significant increases in stress, anxiety, depression, and we did measure loneliness as a construct as part of this. And so, yes, we really do need to be gathering this type of prospective data granularly, I think state by state, and then God, I hope not at federal level, but if we can gather that prospective data, I think we will see that the stress, loneliness, isolation, medical mistrust that comes with oppressive policies will coordinate with increases in the rates of chronic pain.
Thank you so much for sharing that. So this last is some affirmations saying, blessings, thank you so much for your work. I'm a holistic chronic pain coach and wanted to see how I could get more information from your study along with some possible additional participants that I know would love to help.
Absolutely. I would love if we could be e-connected. I'm happy to email with anyone who's interested in talking with me.
Fantastic. Well, please join me in giving a round of applause, snaps, throwing all the glitter to Dr. Andrea Chadwick. Really appreciate all the important work that you're doing and for your generosity and being here with us in community to share back the results. We appreciate you.
Thank you. Much blessings to all of you.
Great. Well, I have the pleasure of welcoming to the virtual stage our next presenter, Dr. Diana Tordoff, who is going to lead us through the second study that's being presented today.
Thank you so much for having me here today. My name is Diana Tordoff, and I use she, her pronouns. For a brief visual description of myself, I have long brown hair, light skin, and I'm wearing a cream sweater with little mushrooms on it. So I'm currently an instructor in the Department of Obstetrics and Gynecology at Stanford, and I recently completed a postdoctoral fellowship with the PRIDE study. Today, I am talking about chronic pelvic pain amongst transgender men and gender diverse adults who are assigned female at birth. So in this study, we aim to better understand chronic pelvic pain amongst transgender people assigned female at birth. Chronic pelvic pain describes pain in the lower abdomen, pelvis, or genitals that lasts 3 months or longer. It has many and often co-occurring underlying causes. So, for example, underlying causes could include gynecological causes, such as endometriosis, urological causes, such as painful bladder syndrome, gastrointestinal causes like irritable bowel syndrome or IBS, musculoskeletal, and lastly, neurological causes. And so in this study, we wanted to know first, how common is chronic pelvic pain amongst trans men and gender diverse people assigned female at birth? And second, if testosterone has any impact on chronic pelvic pain. So what did we know about testosterone and pelvic pain prior to this study? Overall, there's very limited data on pelvic pain amongst transgender individuals. Several previous studies have reported that around a third of trans men using testosterone experience any pelvic pain. And we also have some studies suggesting that some trans men report new onset pelvic pain after starting testosterone. We also know that chronic pelvic pain is one of the most common reasons trans men report for seeking hysterectomy. However, at the same time, testosterone is hypothesized to reduce pain associated with endometriosis and dysmenorrhea, or painful menstruation, through ovulation suppression. However, we know that testosterone does not necessarily fully suppress ovulation in all individuals. And lastly, danazol, which is a drug with androgenic or testosterone-like properties, is a known effective treatment for endometriosis-related pain, which further suggests that testosterone might reduce some types of pelvic pain. So to answer our first question, we included over 2,500 trans men and gender diverse people assigned female at birth. And we found that 18%, or close to 1 in 5 participants, had chronic pelvic pain. Individuals with chronic pelvic pain were more likely to experience inflammatory bowel disease, IBS, kidney stones, pelvic inflammatory disease, polycystic ovarian syndrome or PCOS, uterine fibroids, currently having an IUD or an implanted device that's used to prevent pregnancy, or had ever been pregnant. Notably, people with chronic pelvic pain had a particularly high prevalence of IBS at around 37%, as well as a high prevalence of PCOS at around 20%. We also found that chronic pelvic pain was associated with worse mental health. Specifically, individuals who reported chronic pelvic pain, 51% had a post-traumatic stress or PTSD diagnosis, 42% reported severe depressive symptoms, and 25% reported severe anxiety symptoms. Next, we looked at the association between testosterone and chronic pelvic pain. And to explore this question, we conducted 2 different but complementary analyses. First, we did a cross-sectional analysis where we looked at all trans men and gender diverse participants assigned female at birth. And overall, we saw that testosterone was associated with a 21% lower prevalence of chronic pelvic pain. That is, current testosterone use was protective against chronic pelvic pain. We also did a longitudinal analysis where we looked at changes in chronic pelvic pain over time. So for this analysis, we included a subset of 79 people who had more than 1 year of data and who were starting testosterone for the first time. We included their baseline data and the year before starting testosterone, and then looked at whether they had chronic pelvic pain in the first and second year after starting testosterone. So at baseline, when folks were testosterone naive, we found that 16% reported chronic pelvic pain. Among those who had chronic pelvic pain before starting testosterone, we saw that pelvic pain resolved for some individuals. Specifically, only 62% reported chronic pelvic pain in year 1, and only 56% reported chronic pelvic pain in year 2 after starting testosterone. Among those who did not report any chronic pelvic pain at baseline, we saw that 6% reported new onset pelvic pain in year 1, and 9% reported new onset chronic pelvic pain in year 2. And overall, when we considered the 15 participants who reported any chronic pelvic pain while using testosterone, we saw that approximately half had reported chronic pelvic pain prior to testosterone initiation, and the other half had reported new onset chronic pelvic pain. So collectively, this suggests that for some trans men and gender diverse people, testosterone may reduce pelvic pain, while for others, testosterone may be associated with changes to the reproductive environment that cause new onset pelvic pain. This really highlights the need for future research to examine the association and the impact of testosterone on the specific underlying causes of pelvic pain. So I just wanted to highlight some key takeaways from this study. First is that chronic pelvic pain is common amongst trans men and gender diverse people assigned female at birth, around 1 in 5. We also found that the association between testosterone use and chronic pelvic pain is complex. So some research suggests that testosterone may reduce pelvic pain for some individuals, while for others, testosterone may cause new pelvic pain. And this has several implications for healthcare. It is important that clinical providers not assume that all cases of chronic pelvic pain amongst transgender people are caused by testosterone use. And instead, they should take a comprehensive health history to assess symptoms prior to testosterone use or any dose changes. And lastly, we found that chronic pelvic pain can have a large impact on mental health and overall well-being. So looking forward about what's next following this, and we have several future directions for this research. This past year, we completed 28 interviews with transmasculine people who use testosterone about their gynecological health experiences, including the different types of pelvic pain they experience, as well as their experiences accessing healthcare for pelvic pain. And so based off of these interviews, we are currently developing a new survey that will include focused questions on pelvic pain that have been developed specifically for trans populations. So thank you all for your time. If you're interested in reading the full study, you're welcome to scan this QR code, or you may also use the link in the chat.
Thank you so much, Dr. Tordoff. Really appreciate you taking the time to share this important, impactful research. I'm going to go ahead and jump to the Q&A. We have some great questions in the Q&A function. So the first one is, thank you for considering other conditions that could contribute to chronic pelvic pain. I was wondering about if other data was gathered that is highly correlated in the trans community, such as high sexual assault rates, physical violence, etc.
We do collect those data, and I'm trying to see if we included those measures in the present study. We did not look at those formally in the study, but those are data that we collect through the PRIDE study. And so something we can definitely look at in the future.
Yeah, thanks so much. And I think I want to underscore, the research that Dr. Tordoff is doing is really groundbreaking. And it's, we don't have the foundational data. So it's, each time we hear more feedback from participants, what are the areas, it just gives more to build on and more studies to do. So we appreciate everyone's suggestions, reflections. And folks are invited to ask additional questions in the chat or the Q&A function. We'll go ahead and move to the next question, which is, how do your research findings inform, or how can your research findings inform better pre-medical transition education and consent procedures, especially emphasis on vaginal dryness as a common side effect of testosterone therapies?
Thank you. I think that's a really important question. And so genital atrophy or vaginal atrophy is a known side effect of testosterone use, and something that came up in a lot of the interviews that we conducted recently. And I think we also had not this study, but a study published also, I think it was technically in like December, November of 2023, looking at sexual function and specifically looking at experiences that are typically associated with genital atrophy, such as dryness or pain during sex. And so in this study, we found that testosterone use was not associated with measures of dryness, as it was measured using a specific measure we currently have on the PRIDE study, as well, but it was associated with increased scores on pain during sex. And so I do think this is really important. Something we heard a lot in the interviews is that a lot of folks wish that there were, that they had heard about atrophy during the consent process of starting testosterone. And a lot of folks thought either that won't happen to me, or really didn't have that included in the informed consent process. And so we're both confused and surprised when it happened to them. And so I do think there's a lot to learn there. And yeah, this is talking about atrophy is something I'm particularly interested in. So you can definitely expect more research on that coming out soon.
Thank you so much. Another question that came through is, Has this current administration's attack on trans healthcare impacted/changed your approach to sharing this information, particularly potential side effects of HRT that could be used to deny care?
I think that's super important. I think already pelvic pain and sexual function have been used as an argument against why folks should um, have access to gender affirming hormones. And the truth is, a lot of the science on that is really grossly misrepresented. So, in this same paper that I referenced, on sexual function and pain during sex, we found that testosterone use was actually positively associated with many, many different aspects of folks' sexual health and sexual function and sexual well being. And so, even though folks do experience pain and dryness, that does not necessarily mean that it is negatively impacting all aspects of their sexual health. And so I think nuance is important, and providing the complete picture is important. This current administration does not thrive on nuance, but I think it's important to consider providing informed consent to participants, to people and patients who are starting gender affirming hormone therapy. And thank you, Daniel, for finding that link.
Yeah, no problem. Thanks so much. And for folks that are tuning in, you can read more about the study that Dr. Tordoff was mentioning on that link. And also, it has the full PDF, which I'll type in the chat as well. So our next question comes in our Q&A, which is, I'm a clinical practice. I've seen a significant increase of chronic BV in people initiating testosterone, which could potentially play a part in pelvic pain experience. Lactobacillus is known to respond to estrogen levels and increase during times that levels are higher. Do you know of any literature looking at the changes in genital microbiome of people assigned female using testosterone?
Thank you so much for this question. I currently have a grant specifically looking at this. There has been very little research on how testosterone impacts the genital microbiome, but there has been several publications. So there have been two papers published by McPherson, and I'm happy to hunt down these links after I'm done presenting, who's looked at the impact of testosterone on the microbiome. There's also a current study going on called the Transbiota study. They have not yet published their results, but they're probably going to be publishing their results in the near future. And they're looking at the genital microbiome of both trans folks assigned female at birth, as well as transgender women. So I'm particularly looking forward to those data coming out. Lastly, it is true there is some preliminary studies showing that many folks who initiate testosterone experience new onset BV or chronic BV initially after starting testosterone. So I think this is a really under-researched issue, but does have implications for people's well-being.
Thank you so much. The next question is there a possibility of examining whether there is a difference in perception/incidence of pelvic pain during testosterone therapies for trans and cis folks?
Yeah, I think that's a really important point. So I think the way many questions about pelvic pain are asked really assume a certain set of behaviors and sexual practices, where in reality, like queer folks are, diverse and creative in the ways we have sex. And so I think a lot of folks who experience pelvic pain might avoid certain types of sex because we sort of like live in bodies and in relationships where that type of creative sex is possible. And so I do think it's possible that we're not capturing all people's experiences of pelvic pain, especially pain during sex or penetration. So yes, we are going to look at that in the future.
Well, we are all very much looking forward to hearing more about the really important and impactful research that you have on the horizon. Everyone, please join me in giving a round of applause, some snaps, throwing glitter to Dr. Diana Tordoff. Thank you so much for the research that you do and being here with us to share it with the community.
Thank you.
Fantastic. Well, I am very excited and have the pleasure to introduce to our third researcher for today, Dr. Emilio Compte.
Thank you very much. I'm going to be sharing my slides. I think you can all see my slides.
Looks fabulous. Thank you so much.
Thanks so much. I am Emilio Compte. My pronouns are he, him. I'm an associate professor at the Eating Behavior Research Center at Universidad Adolfo Ibáñez in Chile, and also am the research director at Comenzar de Nuevo, which is a specialized eating disorders treatment center in Monterrey, Mexico. For a visual description of myself, I have a fair skin, short brown hair, and a short beard that matches my hair color. I'm wearing a green shirt, and I'm from Buenos Aires, Argentina. I live in Chile, and today I'm greeting you from Madrid, Spain. This research has been published in Body Image, which is the leading journal of the body image field. And also, I want to say that I'm grateful, I'm very honored to be sharing these findings with you. This presentation is organized around 3 learning objectives. First, we will try to understand what a psychometric tool is and how it helps to measure thoughts, feelings, or behaviors. Then we will learn about the muscle dysmorphic disorder inventory, what is and what it assesses, and also to understand how the MDDI or muscle dysmorphia has association with eating disorders among transgender women. Sorry. Measurement is crucial in research because it defines what we study, allows comparisons, and helps to track changes over time. It supports evidence-based decisions, reveals relationships between variables, ensures replication for scientific validation. However, measurement is not always straightforward. For example, if we want to assess quality of life, we could simply ask people how they perceive it. But quality of life is a broad, subjective concept. That is why measurement tools are developed, incorporating questions or statements about specific and easily observable aspects. Returning to the example of quality of life, Flanagan in 1978 developed a measurement tool where individuals rate their satisfaction with 16 specific aspects on a scale from 1 to 7. Each of these aspects is linked to a broader concept, allowing us to assess quality of life through specific measurable statements. Specifically, we can observe that measurable items as material well-being and financial security and health and personal safety are related to a broader concept of material and physical well-being. Similarly, items assessing satisfaction with relationship with parents, siblings, other relative, having and raising children, relationship with spouse or significant others, and relationship with friends are linked to a more general concept that we might call relationship with other people. Other items in the scales are related to additional concepts, including social, community, and civic activities, personal development, and fulfillment and recreation. This structure allowed us to evaluate broader psychological or social construct using simple but yet question or statement. When we develop or validate a scale, we conduct statistical analysis to assess its quality. There are many indicators, but to simplify, we focus on 4 key ones. Factor structure examines how questions in a test are grouped to measure different aspects of a topic. Internal consistency checks if similar question in a test give consistent results. Convergent concurrent validity confirms if a test aligns with other measuring similar related construct, and discriminant validity that assures that a test is specific to its purpose and does not overlap with unrelated ideas. As a part of a second learning objective, we will reflect on what muscle dysmorphia is and how it is assessed. Muscle dysmorphia involves an obsessive concerns about lacking muscle size or definition, often resulting in extreme fitness or dieting routines and significant impairment in daily life, work, and relationships. Some key clinical features are exercising excessively even when tired or injured, constant dissatisfaction with appearance focusing on perceived flaws, avoiding social events to stick to workout routines, feeling anxious if unable to follow strict fitness plans, and letting body concern disrupt body relationships or daily life activities. To assess muscle dysmorphia, Hildebrand and colleagues developed a tool called the Muscle Dysmorphic Disorder Inventory. This inventory consists of 13 statements that are related to three broader concepts associated with muscle dysmorphia. You can see the specific items below the title of this more general concept. Drive for size, appearance intolerance, and also functional impairment. Drive for size is the desires to increase muscle mass and concerns about size. Appearance intolerance relates to dissatisfaction with appearance and focus on perceived flaw. And functional impairment is the extent to which muscle concerns interferes with the daily life. After administering the MDDI in the PRIDE study, we conducted statistical analysis to determine whether it is a reliable tool for assessing muscle dysmorphia symptoms in transgender women. Looking at the 4 key indicators of an instrument that we discussed earlier, we found that the 3-factor model fits well in this population. The subscales show strong internal consistency, and there was strong correlation with eating disorder symptoms supports its accuracy in capturing related construct. And also, subscales uniquely measure distinct aspects of muscle dysmorphia with a minimal overlap. These are good news, as it confirms that we now have a validated tool to assess muscle dysmorphia in transgender women, filling an important gap in research and clinical practice. Also, these are good news because the results are consistent with findings from other countries' population, which indicates that the MDDI is a reliable and stable tool. This is important because it allows us to conduct studies involving individuals from diverse backgrounds, ensuring that the instrument is applicable across different cultures and demographic groups. It is also important to highlight that previous PRIDE study research findings has shown that the MDDI is a valid tool for assessing muscle dysmorphia in cisgender gay men and cisgender lesbian women, gender-expansive individual, and transgender men. This finding supports the versatility and applicability of the MDDI across diverse gender identities and sexual orientation. And as a part of the third learning objectives, we will analyze the relationships between muscle dysmorphia and a traditional measure of eating disorders. In this graph, each circle represents an association between the MDDI dimension and the eating disorder examination questionnaire dimension. For the drive for size, we observe that this characteristic, typical of muscle dysmorphia, has minimal association with any of the EDQ dimension, as is indicated by the more small circles. Appearance intolerance in this subscale shows significant correlation with the EDQ represented by larger and more defined circles. As expected, the stronger relationship is between the appearance intolerance dimension of the MDDI and the body dissatisfaction dimension of the EDQ, highlighted by a larger, darker blue circle. Functional impairment in this subscale demonstrate moderate association with a different EDQ dimension, show medium-sized circles, larger than those in the first case, but smaller than in the second one. To summarize these findings, we can say about rifle size that no significant correlation with the EDQ subscales, and as the EDQ focus on fitness-oriented disorder eating. In terms of appearance intolerance, strong correlations with shape, weight overevaluation, and body dissatisfaction reflecting shared body image concerns, and mild to moderate correlation with all the brief EDQ subscales highlighting overlap in functional impairment despite the different goals in muscle dysmorphia and eating disorders are pursued. So what did we learn and what insights can we take home from our research? Our finding confirms that the 3-factor structure of the MDDI holds in this population. While appearance intolerance and functional impairment shows association with eating disorder symptoms, drive for size does not, highlighting the need for specific assessment tools beyond traditional eating disorders measures. The scale demonstrates good factor structure, internal consistency, and convergent and discriminant validity, making a useful tool for research and clinical practice. Consistent with previous finding across different demographic groups, including PRIDE study results, reinforce that the MDDI is a robust instrument for studying muscle dysmorphia in various communities. Developing and validating measurement tools specific to diverse population ensures that research and intervention are more inclusive and representative. And finally, while this study is a step forward, additional research is needed to refine assessment tools and to investigate muscle dysmorphia experiences in broader gender identities. Muchas gracias. Thank you very much for your attention.
Thank you so much, Dr. Compte. Really appreciate all of the research, but also the background and the importance of validating these tools. I'm going to invite attendees, if you have questions, please feel free. You could type in the chat box or you could use the Q&A function, whatever works best for you. I'll go ahead and get us started. You and the team that you work with looking at, this topic have quite a impressive portfolio of published research and doing really important work over many years. Could you share a little bit more about, what sort of maybe, and you talked about this a bit and what's next, but talking a little bit more about what you're looking at in this area moving forward, what some of the future research is in this area you're looking at?
Yes, thank you so much for your question, Daniel. There's a story underneath this presentation. For many years, it was believed that eating disorders only affected women. And in 1993, it was first described as syndrome, originally called reverse anorexia. Then it was called muscle dysmorphia, in which we thought that we had found all those cisgender men that did not have traditional fitness-oriented eating disorders, that they will fall into the muscle dysmorphia syndrome, which means the pursuit of muscularity. And there was some, like, how can I say, like the research community was pleased because those men that were not found in eating disorders were found in muscle dysmorphia. But we made a mistake there. It's thinking that men or cisgender men or people who identify as male, they do not have traditional eating disorders, but they do have traditional eating disorders. And on the other hand, we thought that women or people who identify with a female gender did not have concerns with muscularity, but actually they do. We may not found as many men as women or people who identify as women with a thinness-oriented eating disorders, and we may not have many women or people who identify as women with muscle concerns, but we do have. Having a research tool that allowed us to study muscle concerns about a broad spectrum of gender identities would allow us to provide a proper help and to study these specific features without making stereotypes and putting people inside the box. So a good thing here is that we have made a step ahead and we now have a validated tool that will allow us to study people despite their gender identity. Muscle dysmorphia, concerns about muscularity, concerns about thinness, it goes beyond gender identities. And having a research tool will allow us to investigate further this issue. And also, this could be used in clinical practice, and we can help people, as I said before, despite their gender identity, related to the concern of the pathological pursuit of muscularity.
Thank you so much. Really appreciate hearing the story and the context around the importance and kind of getting to this research and your sharing of what you learned through the process. It's really inspiring to hear, the important work that's being done around this topic. And like what you said, breaking down barriers and stereotypes around how these topics relate and resonate to other people across gender identities. Um, the other question that I had was, in this process, whether it's through this study or other studies around this topic, was there anything that stands out to you as being surprising or anything that kind of stood out to you as, oh, this was something that maybe I wasn't expecting or learned?
Well, to be honest, this has been only one research assessing muscle dysmorphia in transgender women, and actually it uses the MDDI before its validation. So the good news is that, as I said before, we're a step ahead. And in a way, the bad news is that we don't have enough research conducted yet. So I think there is much for us to learn. And as I said, the good news is that we can learn now, trusting in a reliable measure.
Thank you so much. Well, want to underscore again, similar to what we were mentioning with Dr. Tordoff's research, the research that you're doing and the team that you're working with is really groundbreaking and foundational. And like what you said, it's laying the foundation for even more studies, the impactful research. So we look forward to welcome you back over many years to continue to share back this research with the community. So everyone, please join me in giving a big thanks, a round of applause, snaps, and throwing lots of glitter to Dr. Emilio Compte. We appreciate all that you do, and thank you for creating space with us today.
My pleasure.
Fantastic. Well, huge thanks, everyone, for all of your great questions. And we invite you all to stay connected with us. You can follow us on social media across all channels. We're at The Pride Study. You can email us at pridenetconnect@stanford.edu. And also, we hope that you sign up for the PrideNet newsletter. This is where you'll get updates about webinars, online events such as this, where we'll be in person, when new research is published, resources. So the link in the chat that Elle posted also will get you to sign up for our newsletter, and you can also scan the QR code. And last but definitely not least, we invite you to join us if you haven't already. If you are a researcher and you're interested in conducting research with the Pride Study data, we have information about conducting ancillary studies, such as the ones you saw today, what the application process looks like, all the other details. The link in the chat that my colleague Elle posted will bring you to that page, and if you scan the QR code to the left. And also, if you are not yet already and you're interested in learning more about becoming a participant, really, it's a great opportunity to have your representation in the data, all the communities that you're a part of. More information is on that second link in the chat and the QR code on the right. Huge thanks to everyone here. Huge thanks to all of our presenters for your impactful research and spending time here with us today to share it back with the community. Thanks to the PrideNet team who is working tirelessly in the background to make sure the webinar is running smoothly. And huge thanks to all of our attendees, our participants in the Pride Study, and our members of the PrideNet network for making all this important work possible. We appreciate you all. Have a great rest of your day. Take care.